Okay, we're going to start the afternoon session by doing a debate for the next 40 minutes. Can I ask Dr. George Haddad, Prof. Ranjit Akolekar, and Prof. Ala El Abrashi to come to the podium, please? Okay, so we thought we were going to do a debate on screening for chromosomal abnormalities or screening in the first trimester scan, a debate to see what we do in Jordan and then compare it to what is happening in France, in England, and in Egypt. And we had a colleague from the States that she had a trauma. Unfortunately, she could not be with us. As you know, screening for chromosomal abnormality is not well established in Jordan. Okay, we have selective screening. We don't have a wide screening. And usually, mainly it's in the private sector, where we have nuchal translucency scan, we have biochemical screening, we have non-invasive prenatal testing, we have invasive procedures, and the fetomaternal specialist in Jordan is a small group. We don't have a big group of fetomaternal. So most of the obstetrics, in a way, is done by a general obs and gynae doctors. The other thing is, okay, termination by law, as you all know, in Jordan is not allowed. But there are maternal indications. If the woman's health is at risk, then you're allowed to terminate the pregnancy regardless of the gestational age, and that's very similar to what Dr. Ala El Abrashi mentioned in Egypt. However, fatawa, we're allowed by religious scholars to terminate pregnancy if there is a lethal abnormality and it's not exceeding 120 days. And there are other implications of medico-legal aspects of screening. So I understand that the majority of the audience are general obs and gynae. So we will start with Dr. Ala and just ask in general about screening for chromosomal abnormalities in Egypt. Just in a couple of minutes, Dr. Ala, تفضل.
Thank you very much. In Egypt, the screening for chromosomal anomalies starts between 12 and 13 weeks. It is mainly the nuchal translucency with the addition of some important markers that increase sensitivity, the nasal bone, ductus venosus, and the tricuspid regurg, maybe the heart rate. When we find this, we put the maternal age into a package, and this package usually is giving you the risk. And your patient will be categorized according to the low risk, intermediate risk, and high risk. This package is supplied by the FMF, and even now we have branches like in France, they have it, their own, and so on. You cannot even be registered as a FMF fellow. You can just get the link on the internet and you just download it and you put the data, crown rump, maternal age, NT, ductus, and nasal bone, and then you will find the results at the end. You don't have to add medical test, like the double test also. This is immediately when you find your patient is low risk, you do nothing. Intermediate risk, you will add the NIPT, or you are go directly to CVS or amniocentesis, which is done, of course, by special fetal medicine. Amniocentesis after 15 weeks, CVS after 12 weeks, and the results will be in your hand between 2 weeks, and then you decide what are you going to do. This is the protocol.
Okay, but Dr. Ala, it's very similar to Jordan. Then you don't have a national screening for chromosomal abnormality. Not every Egyptian pregnant lady will get an NT scan.
Depending on the knowledge of the doctors and depending on the level of the mother. So we are now trying to urge all the doctors that 13-week scan is a must. And later on you are going to ask other questions. I will tell you why it is a must. Screening should be offered to all females in order to know the scenario of the ongoing pregnancy.
Okay, Professor Al-Kira. Yeah, the same question. Screening in the UK, if you can give us an overview of the system, a screening for, or the NT scan and what's next, just like overview of what's happening in the UK.
Yeah, thank you. So the recommendation is that all women, so there are 140 NHS units in England, all screening is based in public hospitals. Private practice is there, but selected centers in London, few places, Birmingham, few places, but 99% of maternity care is based in NHS Trust, number one. Number two, his recommendation is that all pregnant women should book between 8 and 10 weeks with their midwife to do blood tests. And about 92 to 94% of women do that. Number three is they are offered a dating scan at 11 plus 0 to 13 plus 6 weeks. And that scan includes dating, assessment of basic anatomy, which is very limited in most hospitals, except specialist centers, and combined screening for fetal aneuploidies. So they have a risk assessment based on maternal age, nuchal translucency, and HCG and PEPE as a routine for everyone who books before 13 plus 6. If they book late in the pregnancy, as happens in some pregnancies, then they get offered a quadruple screening test that includes estriol and inhibin up to 20 weeks and 0 days. They have reduced it from 22 weeks. They used to do it until 22 weeks, but it is up to 20 weeks. After 20 weeks, the screening based on ultrasound scan or biochemical markers is not there. You can do an ultrasound scan to assess for ultrasound markers, but that is the basic screening.
Okay. Dr. George, in France, what do you do?
In France, it's very easy. Everybody have to be screened, all population in whole France, in public or in private. So it's very easy for us. Every single person who do ultrasound scan, he have to improve that he measure well CRL and NT, and he have a number. It's a number, and every woman have a scan. Every pregnant woman between 11 and 14 weeks, free. It's government who will pay, and she do the scan. And when she do the scan, she have to do it with a person who have this number of identification. We say identification number, and the practitioner, doctor or midwife, have to put on a paper the age, the history, family history, if she have another chromosomal anomaly in the family, and the CRL and the NT. And the woman take this paper and go to the laboratory, and she do PEP-A and beta-HCG, and we have the combined risk. The combined risk is sent to the doctor who done the scan. If it is less than 1 on 1,000, and just normal screening at 22 and 32 weeks. If it is between 1 on 50 and 1 on 1,000, we do an IPT. It's about 11 to 12% of population who are in this category. And more than 1 on 50, we do an invasive test, or if she don't want an invasive test, we can do an IPT instead of invasive test, but we prefer invasive test. Like this, more than 98% of trisomy 21 are diagnosed in France. It's not mean that 98 are terminated, because a lot of women have the diagnosis of trisomy 21 and they don't ask for termination. But 98% have the diagnosis with this combined risk on first trimester. And actually last year in 2024, the very few trisomy 21 who have not been diagnosed is because the woman have endured the pregnancy until 37 or 38 weeks and she arrived was pregnant. But everybody have the diagnosis, because at 22 weeks, if we have on the scan, if we have some anomalies, we can do also the amniocentesis after 22. So actually, and all what I have to say, it's free. The NIPT is free when you have more than 1 on 1,000. The first trimester scan is free, and the second and the third scan are free. Everything is free in France.
Okay, excellent. So actually, if we compare what we're hearing now to 20 years ago, even in the UK or in France, it was a different story. Yes. So things have changed since then.
Yes, sure.
Now, in Jordan, NIPT is offered only selectively. If the woman wants to do it because, or if the fetomaternal or a general obs-gynae is asking her to do it, if she had an history of abnormal baby, Down's baby, for example, or if there are any markers on scan, or the age, for example, above 35, above 40, whatever, because she has to pay for it. It's not covered by the government. So the public health does not cover any cost of NIPT. The cost of NIPT has gone down. I mean, when it all started in Jordan, it was $1,000. Now it's $200 to $300, something like that. So it's not too bad, but lots of people cannot afford it. That's very important. So back to NIPT, Dr. Ala. How are things in Egypt when it comes to non-invasive prenatal testing? Who offers it? When do you offer it? What's the cost? Thank you.
It's not a routine to do an IPT in Egypt. In a very minute centers, I think they do it as a routine for the elite and rich people. Concerning the general acceptance, we usually go for NIPT when we have done the 12, 13 weeks and it showed a high risk or even intermediate risk from the start by its age. But we don't go for NIPT just as an IPT because we believe that before the NIPT would be positive, your NT scan will be giving you much more information or the similar information. Just want to be changing from screening to diagnosis. So this is the situation in Egypt if you want to ask me about it, about NIPT position.
But you mentioned the cost is quite expensive. I mean, it costs an NPT $1,000 in Egypt. That's a lot of money.
No, it is between $300 and $500 nowadays. $300, $500 per test. And sometimes, of course, they make like changes. They make an installment, and if you do three, if you send me 3 cases, I will make something like that. But this is the range, $300 to $500.
Okay. Prof. Kolikar?
Yeah, so I think just in terms of a context, the key to screening for aneuploidies is because a substantial proportion of them, if they are not diagnosed, will have an impact on stillbirth. 40% of fetuses with Downs between 12. I'm saying this context because you mentioned about the need for screening depending on social circumstances and the need for screening also understanding the laws of medico-legal issues but also termination of pregnancies in different countries. So the reason to screen for aneuploidies is 80% of trisomy 18s and 13s will end up in a stillbirth before delivery. And 40% of trisomies will die between 12 and 40 weeks. So there is a need to screen. One is for preventing adverse outcomes, but also to give parents the information. Question is, how do you make sure that you have an effective screening that is offered to everyone at a less cost, but also you increase the detection rate? With NIPT, we have been doing a parallel research study at our hospital at Medway and King's for the last 10 years now. When the NIPT was introduced by the NHS, it is offered as it is in France, free of cost within the NHS hospital to everyone, but only if you are high risk. So if your risk for trisomy 21 or trisomy 18 or 13 is above a certain cutoff, and there is 1 in 150 at term, you are offered the option of having an NIPT or invasive test. If the key is to identify the maximum number of pregnancies with trisomies, they are not the ones that are high risk because the high risk ones will be picked up by combined screening and HCG and PEP and nuchal translucency. The ones that you miss are between 150 to 1 in 500. When we first started the study, we used to have a cutoff of offering NIPT to everyone, more than a 1 in 1,000 risk, but we had no babies with trisomies between 1 in 500 to 1 in 1,000. So now, as you heard from Dr. Al-Brashi, that we offer it between 1 in 500 to 1 in 150, and more than 1 in 150, we recommend an invasive test. This is in our fetal medicine centers, but from a national perspective, you are offered NIPT in the public hospital free of cost if your risk is high, which is more than 1 in 150 at term. In terms of the cost of the NIPT, depending on which company you go to, if you go to Roche, the cost is about £195. If you take a test from BGI, it is £150. And then they add on several microdeletions, 60 microdeletions, which we should not go for yet because there is no research around it. But the cost to the company rather than the provider because I may charge a different cost to the patient, and different people will charge different costs, but the cost to company is 120 to 150 pounds for a sequential test.
Okay, Dr. Haddad.
Yeah. So for about France, I'm one thing. When you measure the NT and the NT is more than 3.5 millimeters or more than 95 percentile, NIPT is not a good test at all, because 34% of chromosomal anomalies of when the NT is more than 3.5 are not detected by NIPT. So if you do NIPT and you have no trisomy 21, you are obliged to do invasive test. So this is why if you have markers and very hard markers, efficient marker like NT, we decided not to do NIPT and to go immediately to invasive. This is the first thing. Now, second thing, NIPT for everybody, even if people want to pay, the problem is when you have a very low risk. For example, a woman, she have 1 on 5,000 risk of trisomy 21 and NIPT. If she do the NIPT and if the NIPT is positive, the risk of false positive is 5 times more than a real positive. The risk when he's very, very low, 1 on 10,000, you have more false positive than real positive. So when you have a test positive, you have to do invasive tests. So it costs double to the woman. So as they have done in UK, from 1 on 1,000 to 1 on 10,000, without any marker, without any problem on ultrasound, it's crazy to do NIPT because you have more problem than it's resolved. Okay? The price is getting down in France, and now it's about 180 euro paid by the government. But now, since this month, in September, we decided to do all genome. It means that we do NIPT for chromosome 2, for chromosome 15, for chromosome 16, for 22, we do everything, and you are less and less. It means even the deletion and really very little anomalies in fetus, we can diagnose them in NIPT. So the price will stay like this, but the efficiency of NIPT will better and better, because now we can see a lot of malformation, even structural anomalies on baby.
Okay. And it's important to emphasize the fact that NIPT is a screening test. So if it comes high, you have to do a diagnostic test. Otherwise, you have to be careful. Now, my next question is, do you think a 13 weeks scan is an anatomical scan or a screening test, Dr. Ala?
Okay, I was waiting for this question. Thank you very much. 13-week scan now is not considered as an anti-screening test, anti-screening scan. Before 20 years ago or 15 years, it was named like this, anti-scan. Now, with the advancement of the knowledge and the machines and the investigations and the papers, we are able to get 60 to 70% of the fetal anatomy. And these types of fetal anatomy is very obvious. It's not only, it doesn't need so sophisticated ways to understand. For example, nowadays we can have all the anterior abdominal wall defects, the bladder dilatation, the heart abnormalities. Of course, this needs some experience. The cranium, the face, the limbs, all these are amenable now to the diagnosis. So I would consider the future of the 13-week scan. Definitely part of it is NT, but plus now we have a very important anatomical structures that could be diagnosed as early as 13 weeks. What are we going to do? This is your job. This is the role of the fetal medicine, is to consult, how to counsel the patient for all the scenario of the ongoing pregnancy. For example, if I tell her that this baby have a left side hypoplasia, she's not going to diagnose this, or not waiting to diagnose at 22 weeks. Does this baby have a very bad prognosis? The same is a large omphalocele, gastroschisis, heart anomalies, open spina bifida. All now are speaking about open spina bifida with the hysterotomy or fetoscopy or whatever, but they have not considering open spina bifida diagnosed at 13 weeks. I always urge with them, I just give me 1 minute. You are doing mom procedures and you are doing open spina bifida at 20, 22, and now they have a good results. But what is the ultimate outcome? You have incontinence to stools, incontinence to urine, still, motor is plus or minus. You are saving definitely the brain ventriculomegaly. So you don't need shunts, but the outcome still, it's not good. So if you diagnose open spina bifida by 20 weeks, or if you diagnose open spina bifida by 3 weeks, 13 weeks and 15 weeks, this is a great difference.
Okay, we have Dr. Samer Ba'ba tomorrow. He's covering the surgery, fetal surgery and open spina bifida, and we maybe will challenge him on the long-term outcomes. Dr. Samer Habibi, thank you. Professor Akolikar, again, the same question?
Yeah, I agree completely that the 12 weeks, so the assessment of, there are no screening scans. You have the 12-week scan, which is examination of fetal anatomy at 12 weeks, examination of fetal anatomy at 20 weeks, and examination of fetal anatomy at 36 weeks. The 36 weeks as well is not a growth scan, it is a scan with growth and anatomy. Because there are certain abnormalities you pick up at 12, certain at 20, and certain at 36, because you will miss them at 20 and 12 weeks. From a 12 weeks point of view, there is a checklist, and I mention that with confidence because we do that every day. I work in a fetal medicine unit where there are 100 nuchal scans, 11 to 13 weeks, done every week. And we have a checklist that every sonographer, every midwife has to follow the same pathway. So 100 out of 100 pregnancies with holoprosencephaly, acrania, cleft palate, which is a large cleft palate, major, lethal, life-limiting cardiac abnormalities, tricuspid atresia, hypoplastic left heart, severe tetralogy with pulmonary stenosis, including situs abnormalities. These are first trimester diagnosis. Spina bifida, severe diaphragmatic hernia, gastroschisis, exomphalos, lower urinary tract obstruction with bladder outflow obstruction and luto, and bladder exstrophy, transverse limb defects, and severe forms of lethal skeletal dysplasia, which include achondrogenesis, thanatophoric dysplasia, and severe forms of osteogenesis imperfecta, is a 12-week diagnosis. Advantage, especially in your setting, is you can do a first trimester diagnosis, give the report, confirm the diagnosis before 16 weeks to give the parents the choice of what they want to do. From a general obstetrician point of view, the key is understanding what is normal. If all of you cannot be trained, as Dr. Maita mentioned, that there are few fetal medicine specialists, but that is everywhere in the world. Even in England, there are few fetal medicine specialists and people who screen. So your job is to screen the fetus for normal anatomy. Anything that is not normal is to be referred to the fetal medicine specialist to diagnose these abnormalities in the first trimester.
Okay, Dr. George?
Yeah, it's okay. So I have two answers. The first, I agreed what I've been just say before, but you know, as we say today, all of you are screening in first trimester. So in France, in French college, we decided to just put on the first trimester at 13 weeks, 13 items to see. Why? Because we wanted that everybody can screen. It's, for us, it's very difficult to, what to say, it's not very difficult, it's difficult to have 100% of cleft palate at the first trimester. So we decided not to put an item for cleft palate of first trimester. We just put items that all of you, all people who screen, can see them more than in 90% of cases. For example, encephalocele, the abdomen diameter, the PPD, and to diagnose spina bifida. So our 13 items are accessible for all people in France, obstetrician and midwife can do these 13 items. If they find something not good, they ask to an expert to see them after. This is very important. We can see a lot of things. Even at 13 weeks, people we can see corpus callosum. It's ridiculous. We don't have to see it on the first trimester. My second observation is about genetic tests. You know, we have a lot of genetic tests. We have the CGH array, we have the exome, we have the NGS, and we have all genoma. All these take times, and we cannot begin everything in the same time. It means that if you have some markers, you think it's a trisomy trisomy 21 or 18 or 13, you just have to do a FISH, and the FISH is about 24 to 40 hours after you can have the results. We can do CGH, but if CGH is not, FISH is normal, karyotype is normal, and CGH is normal, you can take your time. For example, in spina bifida, we can ask for exoma. Like this, you are sure that we'll have the answer before the third trimester. This is very important. If you do the diagnosis just in second trimester and you decide at 24 or 25 weeks to do all the exome, you'll have the answer after birth. So it's not good. This is why the first trimester scan is very important, especially now that we have a lot of genetics exam, biologic exam.
We'll touch on that, but a quick answer to the next question from all of you is if you find out a lethal abnormality or a severe abnormality in the first trimester scan or in the second trimester scan, what's your plan of management? George will come this way.
Severe
in France, say
France.
If at 13 weeks and
France,
at 20 weeks.
Yeah, in France we have a law. We have every week a meeting in the 78 region of France. Every week we have a meeting for everybody. We say it's a multidisciplinary meeting. For us in Tours, where I'm working in center of France, it's every Monday evening. Every Monday evening we have this meeting, and all malformation diagnosis in first, second, or third trimester have to be discussed in this meeting. And in this meeting, we have to answer if it's a poor diagnosis and there is no treatment. If it is poor diagnosis and no treatment, our conclusion is if the parents want termination of pregnancy, we accept or we don't accept. The legislation in France gives us the possibility to accept a termination of pregnancy all over the pregnancy, even at 41 weeks. It depends of the situation. We don't have limit to stop the pregnancy, to terminate the pregnancy.
When do you do feticide before terminating? After 22 weeks? Or?
Now after 20.
After 20.
After 20 we do feticide, yes.
Okay, Professor Akulikar?
Yeah, similar setup that we have as Dr. Haddad mentioned in France. If there is a lethal abnormality at any stage of the pregnancy, which is usually picked up at 12 or 20 weeks, then women are offered the option of a termination. Many people will choose to have a termination. There are many people who are committed to the pregnancy regardless of a diagnosis of trisomy or hypoplastic left heart for religious, personal reasons or moral reasons. Some people carry on the pregnancy, but they have the option of choosing to stop the pregnancy. Yes, I agree, we do the feticide after 20 weeks. Before 20 weeks, we usually don't. And again, like in France, we have the option of offering the option of a termination if a diagnosis of lethal abnormality is made at any stage in the pregnancy. And an example at 36 weeks would be, because we do a routine 36-week scan, so if I find the head circumference is less than the 3 standard deviations of the third centile, we do an MRI, and it shows severe polymicrogyria with severe impact on neurodevelopment, the parents have the choice of considering to have a termination and a feticide at 37 weeks, if that is the case, or if it's a late diagnosis of a major abnormality such as duodenal atresia, which then comes out as trisomy 21, they can choose to stop the pregnancy at any stage. But generally speaking, lethal abnormalities 12 and 20 usually is the case.
But as far as I know, not all units will offer a third trimester scan in the UK, right?
90% don't. So
90% don't.
90%
So you are
don't.
in the 10%.
We are in the 10%. 90% of units offer a third trimester scan for selected indications that are mentioned in the Royal College guidelines, which include those that are risk factors associated with SGA. There is no routine third trimester scanning. 10% of hospitals in UK offer a routine third trimester scan, and we are one of those few that offer.
Okay. Dr. Ala?
We are in the Arab world. We are in a miserable case, of course. We cannot get near the fetus after 19 weeks. Okay, so by any means, it is very bad situation. That's why I always say it's much better to see these abnormalities and to prove them, either it's alone or having a genetic background, before the 120 days. Okay, this is for Muslims, of course. So for the Christians, it's another situation. So that's why I'm telling you, if you are doing the 13-week scan and you find anencephaly, this is simple. They are going to terminate. Holoprosencephaly, it's okay. But what if you find trisomy 21? You are now in a dilemma, because I am not going to put myself in the situation of the mother. The mother should know everything about this and should consult the family, and then she's coming back to me with a decision. Okay? This decision should be based on the fact that she has already taken the reference of some Muslim sheikh or whatever. And based on that, she's going to do it. Even it is not approved by law. It is not approved by law that you do this termination. So you take some side channels, you say that this baby is missed abortion or something like that. Once you are more than 18 weeks, it is a real problem. And I have a lot of cases that coming from certain areas, and it's like they have a large omphalocele or gastrochysis or a heart anomaly, and she is 24 weeks and nobody wants to do it. The doctors have the right to say no. This is a right for the doctors. And in this time, the patient is in a dilemma. So that's why I'm telling you the importance of 13 weeks. It is a better vision. You can even give her some counseling early. She can think what is the situation. She have the time to consider all these issues. So if you decide to terminate, it will be much easier based on our religious and our traditional communities in this Middle East.
Okay, thank you. Very similar to Jordan. Type again, a question, quick answer, please, from the panel. When, I know, George, this is a close area to your heart, genetic testing. Again, when would you request genetic testing? And in France and the UK, it's probably covered by the government. In Jordan and Egypt, then they have to pay for it. And all these tests are expensive. So
Well,
when would you think it's important to do genetic testing?
It's very easy for us. The genetic testing are always decided in multidisciplinary meeting. So we have nephrologic, we have pediatrics, we have cardiologists, we have geneticists. So every time I have malformation, if it is mild malformation, we present, and sometimes I say, oh, we have a paper about this, now we can search about this panel of genetics, and the geneticists say, we'll do it. And nobody pay. Now we have a special envelope, a special money from the government for genetics in prenatal. We take in this. It's not the primary insurance. It's not the insurance. It's really the government who pay us for this test, for genetics test.
Okay. Okay, Prof. Akulikar. The same question.
Yeah, I think we have the same situation. The genetic testing is funded by the Department of Health. The primary test is if you are high risk for aneuploidies, then you get a PCR test. If the PCR is normal and there are structural abnormalities, then you get a single nucleotide polymorphism array, microarray, which is SNP microarray, and there are specific indications if the nuchal translucency is more than 3.5, or if there are other defects, then you get this SNP array. There are specific indications that if you have a normal PCR, so if you do a prenatal testing and if you have a normal PCR, if you have a normal single nucleotide polymorphism array, you can be eligible for a whole exome sequencing dependent on the kind of indications and the things you find on the scan. And if the nuchal translucency is more than 6.5, or if there are multiple combinations of defects, where there is a checklist and there is a panel of geneticists that review these things. So you can have the whole exome sequencing. And then if there are specific findings on the ultrasound scan which require mutation testing, so if I find that their baby has really short long bones and there are fractures I see on the scan, I will request for mutation testing straight for osteogenesis imperfecta. Or if I find a lethal skeletal dysplasia and my clinical impression is that this is thanatophoric dysplasia, I will request for an FGFR3 directly, avoiding to doing the array and the whole exome sequencing to not waste money or that. And then if there are patients with fetal bradycardia or long QT, you can get a specific panel of mutations for those conditions, but it depends on the diagnostician to request that mutation panel. But the sequence of tests available is QFPCR, single nucleotide polymorphism array, whole exome sequencing, and mutation analysis. They do a automated karyotype instead of an array when they have to confirm the results of the PCR, because there have been cases where the PCR is not 100%, and there have been discrepancies between the PCR and the karyotype. But those are the battery of genetic tests that are available.
Dr. Ala?
No, we don't do so simple, because we only do genetic testing based on the history of the mother. If the mother is having some history of repeated abnormality, autosomal recessive, skeletal abnormalities, and so on, we can do it start from the 13-week scan. But if you find some abnormality with the 13-week scan, which is suggestive of a genetic background, we will go with the whole seek, but she's going to pay. So we have to select these cases, and actually you bring the genetic with me and I tell him what is the best to do for this case and what is the hopes in this case, considering the whole genome or the specific part of the deletions or so, but not a routine.
Okay. My last question is if any of you become a decision maker or Minister of Health in your country, like George, if you're a Minister of Health in France, what would you change policy-wise? Would you change anything regarding the policy of screening in first trimester? Is there anything you would change from what's happening in France now?
Let me tell you, the screening in first, second, and third trimester in France, and especially in first trimester because it's subject today, it was ourselves who have changed. We decided. It's mean the French college went to the ministry and say, this is what we want, and we explained this by studies, by a lot of things that we have done, and the government was
the evidence.
obliged.
You mean the evidence? You convince them with the evidence.
We have evidence. It's like this, and actually, what's happening in France, we decided it. It's not the government who decided. We decided.
So the government is supporting you.
Is supporting. Is saying okay, but for sure they have ethic considerations, so they have to be the guardian of the ethics. So they say you have to discuss in a multidisciplinary meeting. For example, not tomorrow, on Monday, I have a control from the government to our center to see or if all files are good, if we respect the law, is if we signed the termination of pregnancy, if we signed the diagnosis, if we signed for genetics exam. So every 2 years they come, and now they will be 2 days, the 6th and the 7th of October, they are in my center, and they have to see all what we have decided, so they can give us the permit to continue this.
Okay, Prof. Akolikar, if you are the Minister of Health in the United Kingdom.
The chance for that is 0%, by the way. Even if I was the most eligible candidate, the chance is 0%. But if I was in that hypothetical situation, I would make sure that the 12-week scan does three things: dating of the pregnancy, screening for aneuploidies, and to change screening for preeclampsia and growth restriction, which is not done effectively at the moment. It is based on previous history. That if you had a previous pregnancy with preeclampsia, or if your sister had preeclampsia, or if you have chronic hypertension, no. Exactly as we do for fetal trisomies, combined screening for placental insufficiency at 12 weeks. Number 3, a fetal anatomical scan, universal, because as we have all discussed, that it is early identification of lethal fetal abnormalities at 12 weeks. From the woman's point of view, it is different to have a termination at 12 than to have a feticide at 22 weeks and then a termination, whether she is in Jordan or in England. So early diagnosis of fetal abnormalities, these are first trimester. Second trimester, universal screening with uterine artery Dopplers and cervical length for premature birth for everyone. There is no point in doing, as we do now in England, a perfect anatomy scan, NIPT testing, whole genome sequencing, next generation sequencing, and forget the fact that she has an open cervix. There is absolutely no point. So universal cervical length screening for everyone, and not to do the a la carte system of selecting who has a growth scan. Everybody should have a third trimester scan. It is a minimum standard of care. That's what I would change.
Thank you. Dr. Ala?
Number one, I have to standardize the 13-week scan, and it's already standardized, so you have to follow whatever guidelines you have. Then I would urge all the obstetricians to refer the case at 13 weeks. You are putting too much burden on the obstetricians. Obstetricians cannot, and the gynecologists, they cannot learn hysteroscopy and laparoscopy and IVF and doing NT scan. They cannot. So what you can take this responsibility out of them. 13-week scan for me is more important than the mid-trimester scan. It is extremely important if followed this. So this is number one. Number two, I am going to select the crown rump length to do it. If we are now speaking about fetal anatomy, then you have to start between more than 65, 70 millimeter. It is 45 to 85. So don't have 11 weeks doing NT. You will only see the NT, but you're not going to see the heart, not going to see others. So I would push the 13-week scan to the end of the spectrum, which between 70 to 85. So now you will have a very good idea, a very good impression about seeing the fetal anatomy. Then adding to my colleague that you have to screen for preeclampsia. This is very simple and very easy, part of the scan. So as you see, 13-week scan, you can finish everything. And you can give the scenario of ongoing pregnancy, and you don't have to examine a patient again except after 24 or 26. Nothing will happen. So I would standardize, I will push 13-week scan, I will refer all cases, and I will have the report, and you will find your service to the mother and natal is totally different story.
I will definitely introduce the screening in Jordan across the board, because that's something I think we need. Selective screening is fine, but it's not a good thing. We should introduce screening in all sectors of health in Jordan. We have the government, we have the military, we have the universities, we have the private sector, and I think it's the duty of the government to introduce a program of screening in the first trimester and train people to do first trimester scan so we can pick up all the problems, all the abnormalities, and act on them. And that's something which is very, very important. And that's something which I think we, as the government of Jordan, should do. With this, I conclude the debate.
Can I just make
please.
One small point? As I was listening to everyone, I was thinking that if I really was in that situation, which as I said, I will never be, one of the things we don't do well in England is training people.
Yeah.
One of the things that I would change if I was the Minister of Health is I would make sure, because training for obstetric ultrasound for obstetrics and gynecology trainees is not good.
Sure.
And we have the surveys from the trainees. They are the future of medicine, and we are not training them well to examine fetal anatomy. We are putting a sticking plaster in a tick box. So I would want to invest time and energy in making sure that everybody who does obstetrics and gynecology is able to have a minimum basic standard of assessing fetal anatomy. It is part and parcel of obstetric training.
Okay, George.
Yes, I wanted to say something amazing, something in France. I explained to you that every practitioner have to put CRL and NT on a prescription, and the woman go to the laboratory to do combined test. You remember I told this. Now, when she go to the laboratory take the name of the physician, the CRL and the NT. And the last on the year, we give the practitioner his multiple of median. And if it is very low, it means that he have done, for example, 60 scan of first trimester in 2024. And he measured all NT and all CRL. And his multiple of median is 0.6. The normal has to be 1. 1, it's the middle. If he's on 0.6 multiple of median, it means that he cannot measure NT like we can have measured. So we'll ask him to do evaluation of his practices, to send us 10 images of NT to be sure that he's measuring the NT well, and at the same time, we can see if he's doing well the first trimester exam. Because when we do well the NT, perhaps we can do also well, but when we don't measure well the NT, it means that we cannot see other malformation. So when the medium is very, very low, we ask him to send us 10 exam so he can have the identification for next year. You understand what I say? So this is what we say, dynamic evaluation of practitioners. Dynamic, it's every year. For example, this year I received my medium, I was 1.02, it's very good, it's okay. 1.02 for me, I can continue like this. If my medium was 0.7, I have to do an evaluation of my practitioner.
Okay, thank you. It's training very important. I would like to thank the panel and conclude this session. And I would like to ask Dr. Osama Bataini Abdelnabil Bdour to introduce the next session. Thank you very much.